tingling in your fingers, numbness in your feet, a burning sensation that keeps you up at night, muscle weakness that was not there 2 years ago. You went to your doctor, you had tests done, and somewhere along the way you were told, this is just aging. Nerve damage happens. There is not much that can be done. But nobody asked you one critical question. What medications are you currently taking? I want you to do something after this video. I want you to go to your medicine cabinet and look at every single pill you are taking, everyone, because one of them, possibly more than one, may be the exact reason your hands tingle, your feet feel numb, and your balance is quietly getting worse. Drug-induced peripheral neuropathy is one of the most underreported and most misattributed conditions in senior medicine. When nerve symptoms develop in a patient who is already taking multiple medications, which most seniors over 60 are, the damage is almost never traced back to the drugs. It gets blamed on aging, on diabetes, on unknown causes, but the research is there, the mechanisms are fully understood, and the drugs are identified. 6 medications, 6 of the most commonly prescribed drugs in the world for conditions that affect seniors specifically: cholesterol, blood sugar, infections, acid reflux, pain, and all 6 have published clinical evidence showing they can damage your peripheral nerves with long-term use, slowly, quietly, one dose at a time, and most patients taking them have never once been warned. My name is Dr. Michael Kent. I have spent over 20 years in medicine focused entirely on senior health. And today, I am going to name every single one of these 6 drugs, what they are doing to your nervous system, how fast the damage develops, and exactly what you need to say to your doctor at your next appointment. This is not about stopping your medication without guidance. This is about what every patient over 60 has the absolute right to know. Stay with me, because number 4 on this list is a drug that almost every senior has either taken or been offered, and almost nobody has ever been told about this side effect. Before I name the 6 drugs, I need to make sure you understand what peripheral neuropathy actually is and why it is so serious. Because I think most people hear the words nerve damage and picture something dramatic, a sudden loss of feeling, a visible injury, something obviously wrong, but that is not how drug-induced neuropathy works. And that is exactly why it goes undetected for so long. Your peripheral nervous system is the vast network of nerves that extends from your spinal cord outward to every part of your body, your hands, your feet, your organs, your skin. These nerves carry 2 kinds of signals: sensory signals, information traveling from your body back to your brain, including touch, temperature, pain, and position, and motor signals, commands traveling from your brain out to your muscles telling them to move. When peripheral nerves are damaged by disease, by toxins, or as we will discuss today, by certain medications, both types of signals are affected. Sensory damage produces the tingling, numbness, burning pain, and hypersensitivity that so many seniors describe. Motor damage produces weakness, loss of coordination, and balance problems. And because the longest nerves in the body, the ones reaching all the way down to your feet, are the most vulnerable, the symptoms almost always start in the feet and hands before progressing upward. This pattern of symptoms, starting in the feet and hands, is called a stocking glove distribution, and it is the classic presentation of peripheral neuropathy regardless of the cause. When a doctor sees this pattern in a senior patient, the default assumption is diabetes, which is a real and common cause of neuropathy. But when that same patient is also taking one or more of the 6 medications I'm about to describe, the drug contribution to those symptoms is almost never properly investigated. Now let us go through the 6 drugs. Drug number 1 is statins. Statin medications, including atorvastatin, simvastatin, rosuvastatin, and pravastatin, sold under brand names like Lipitor, Zocor, Crestor, and Pravachol, are the most widely prescribed class of drugs in the world. They are prescribed to lower cholesterol and reduce cardiovascular risk. And they do work for that purpose. The evidence for their cardiovascular benefits in certain patient populations is real and meaningful, but statins have a well-documented effect on peripheral nerves that is almost never discussed when the prescription is written. Statins work by blocking an enzyme called HMG-CoA reductase, which your body uses to produce cholesterol. But that same enzyme is also involved in the production of coenzyme Q10, or CoQ10, a compound that is essential for mitochondrial energy production in every cell in your body, including nerve cells. When statins suppress this pathway, CoQ10 levels in nerve tissue drop. Nerve cells become less able to produce the energy they need to maintain and repair their myelin sheath, the protective coating around nerve fibers that allows signals to travel efficiently. Over time, that myelin degrades and nerve function deteriorates. A study published in the journal Neurology found that statin use was associated with a significant increase in the risk of peripheral neuropathy, with long-term users having up to 4 times the risk compared to non-users. The risk was dose-dependent, meaning higher doses produced greater risk and increased with duration of use. If you are on a statin and experiencing tingling, numbness, or muscle weakness, particularly if these symptoms began or worsened after starting the medication, this connection deserves a serious conversation with your doctor. Ask specifically about CoQ10 supplementation, which some clinicians recommend alongside statin therapy to partially offset this side effect. And ask whether your current dose is the lowest effective dose for your specific cardiovascular risk profile. Drug number 2 is Metformin. Metformin is the first-line medication prescribed for type 2 diabetes, and it is one of the most commonly prescribed drugs in the world. For most people with diabetes, it is effective, well-tolerated, and genuinely important for blood sugar control. I am not suggesting anyone stop taking it without medical guidance, but there is a side effect of long-term metformin use that is extraordinarily underappreciated and extraordinarily relevant to the nerve symptoms I described at the beginning of this video. Metformin blocks the absorption of vitamin B12 from the gut, not partially, significantly. Long-term metformin users have measurably lower B12 levels than non-users, and studies suggest that up to 30% of patients on long-term metformin develop clinically significant B12 deficiency. Vitamin B12 is not optional for nerve health. It is the primary nutrient responsible for maintaining the myelin sheath around peripheral nerve fibers. Without adequate B12, myelin degrades, nerves become exposed, signals travel poorly, and the symptoms are identical to diabetic neuropathy: tingling, numbness, burning pain in the feet and hands. Here is the tragic irony. A diabetic patient on metformin develops nerve symptoms. Their doctor assumes it is diabetic neuropathy. The metformin continues. The B12 deficiency worsens. The nerve damage progresses. And the actual cause, a simple, correctable vitamin deficiency caused by the medication, is never addressed. If you are on metformin and experiencing nerve symptoms, ask your doctor to check your B12 level, not just whether it is within the normal range, but where specifically it falls within that range, because the lower end of normal is associated with neurological symptoms even when technically not deficient. And ask about B12 supplementation, specifically methylcobalamin, the form most bioavailable for neurological use. Drug number 3 is certain antibiotics, specifically the fluoroquinolone class. Fluoroquinolones include ciprofloxacin, levofloxacin, and moxifloxacin, antibiotics prescribed for urinary tract infections, respiratory infections, and other bacterial infections that are extremely common in seniors. In 2016, the FDA added a black box warning, the strongest warning the FDA can require on a medication, specifically about fluoroquinolone-associated peripheral neuropathy. The warning states that fluoroquinolones may cause peripheral neuropathy that can be permanent, not temporary. Permanent. Fluoroquinolones damage nerves through a mechanism involving mitochondrial toxicity. They impair the function of mitochondria within nerve cells, reducing energy production and triggering oxidative stress that damages nerve fiber structure. The damage can begin within days of starting the medication and in some patients persists or progresses even after the antibiotic is stopped. For seniors with uncomplicated urinary tract infections, the most common reason fluoroquinolones are prescribed in older adults, guidelines from the Infectious Diseases Society of America now recommend other antibiotic classes as first-line treatment precisely because of this risk. If your doctor recommends a fluoroquinolone antibiotic, it is entirely reasonable to ask whether an alternative antibiotic would be appropriate for your specific infection. Drug number 4, and this is the one I promised would surprise you. Drug number 4 is proton pump inhibitors, PPIs, the drugs prescribed for acid reflux, heartburn, and stomach ulcers. Omeprazole, esomeprazole, lansoprazole, sold under brand names like Prilosec, Nexium, and Prevacid. These are among the most widely used medications in the world. Many seniors take them daily for years. Many buy them over the counter without a prescription. And almost none of them have ever been told that long-term PPI use is associated with peripheral neuropathy. Here is the mechanism. Proton pump inhibitors work by drastically reducing stomach acid production. Stomach acid is not just for digestion. It is essential for the absorption of vitamin B12 and magnesium from food and supplements. Long-term suppression of stomach acid with PPIs leads to chronic B12 and magnesium deficiency in a significant percentage of users. Magnesium is critical for nerve function. It regulates the activity of ion channels in nerve cell membranes that control how electrical signals are generated and transmitted. Magnesium deficiency causes nerve hyperexcitability. The nerves fire too easily and too intensely, producing exactly the tingling, burning, and cramping sensations that PPI users often develop and almost never connect to their heartburn medication. The FDA issued a safety warning about PPI-induced hypomagnesemia and its neurological effects in 2011, and yet millions of seniors continue to take these medications long-term without their magnesium or B12 levels being monitored. If you have been on a PPI for more than 12 weeks, which is longer than these medications were originally designed to be used, ask your doctor whether you still need it, whether the dose can be reduced, and whether your B12 and magnesium levels have been checked recently. Drug number 5 is amiodarone. Amiodarone is a powerful antiarrhythmic medication prescribed for serious heart rhythm disorders, including atrial fibrillation, a condition that becomes increasingly common after 60. It is an effective drug for a serious condition, but its side effect profile is extensive and its neurological effects are among the most serious. Amiodarone contains a very high concentration of iodine. Approximately 37% of its molecular weight is iodine. It accumulates in tissues throughout the body, including nerve tissue, where it causes direct toxicity to the myelin sheath and the axons of peripheral nerve fibers. Amiodarone-induced peripheral neuropathy is well documented in the medical literature and can develop even at therapeutic doses after months or years of use. If you are on amiodarone and developing nerve symptoms, this requires an urgent conversation with your cardiologist. The decision to continue, reduce, or change the medication must be made carefully in the context of your heart condition. Stopping amiodarone suddenly can trigger serious cardiac events, but the neurological side effects must be part of that conversation. Drug number 6 is certain chemotherapy agents, specifically platinum-based drugs like cisplatin and oxaliplatin, and taxane drugs like paclitaxel, as well as some older medications used for non-cancer conditions, including colchicine for gout and thalidomide derivatives used for certain inflammatory conditions. Chemotherapy-induced peripheral neuropathy is the most recognized form of drug-induced neuropathy and the one most likely to be disclosed to patients before treatment begins. But for seniors receiving these medications, including those using colchicine for chronic gout management, the cumulative neurological burden of these drugs, combined with age-related nerve vulnerability and other medications, can produce neuropathy that is more severe and less reversible than in younger patients. If you are on any of these medications and developing nerve symptoms, comprehensive neurological monitoring should be part of your ongoing care. Do not wait for symptoms to become severe before raising this with your doctor. Now, let me give you the practical framework for protecting yourself. The first and most important thing you can do is bring a complete medication list to every doctor's appointment, every pill, every supplement, every over-the-counter medication, and specifically ask your doctor or pharmacist, do any of these medications have peripheral neuropathy as a documented side effect? Ask them to check for interactions and cumulative risks, because when multiple medications each carry a small neuropathy risk, those risks can compound significantly. The second thing is to request monitoring. If you are on statins, ask for periodic B12 and CoQ10 assessment. If you are on Metformin, ask for B12 monitoring at least annually. This is actually recommended in diabetes guidelines, but frequently not done. If you are on a PPI long-term, ask for magnesium and B12 levels. Make this a routine part of your care. The third thing is to pay attention to early symptoms and report them immediately. The earlier drug-induced neuropathy is caught, the more reversible it is. Do not dismiss tingling or numbness as normal aging. Do not wait for symptoms to interfere significantly with daily life. Report them at your next appointment and specifically ask whether any of your current medications could be contributing. And the fourth thing, which I cannot emphasize strongly enough, is never stop or reduce any prescription medication based on information in this video or any other video. The medications I have discussed today are prescribed because they address real, serious, sometimes life-threatening conditions. The goal is not to stop taking them. The goal is to have an informed, specific, evidence-based conversation with your prescribing physician about monitoring, dose optimization, and whether the benefits of your current regimen continue to outweigh the risks as your health evolves. That is what informed medical care looks like, and you have every right to demand it. Please leave a comment below and tell me, were you aware that any of these 6 medications could affect your nerves? Has your doctor ever discussed this with you? I read every single comment on this channel and I reply to as many as I can. If this video gave you information you did not have before, please share it. Share it with someone over 60 who is taking multiple medications and experiencing symptoms they cannot explain. You may be giving them the piece of the puzzle their doctor has not provided. Subscribe to this channel for weekly senior health videos that give you the honest, research-based information your health deserves. The information that helps you walk into your doctor's office prepared, informed, and in control of your own care. I am Dr. Michael Kent. Thank you for watching. Your nerves carry every sensation, every movement, every moment of independence you have. Protect them. I will see you in the next one.